Good afternoon, everyone. My name is Ann Conrath with the Avant-garde Health team. Really excited that everyone is joining us this afternoon for our CMS TEAM Collaborative, which is a group of health systems and leaders like you all that are tasked of implementing bundle payments and team within your hospitals and health systems. The topic for this afternoon is going to be focused on the quality measures. So what are the quality measures? How are they calculated? What are the different components that CMS is using for the methodology and calculating that? And then most importantly, what does that mean for you all? How does that impacting your reconciliation, the financial amount that your hospital will be receiving? And then we're going to get into some nuts and bolts of how to implement bundle payments with discharge planning. So, what are the best practices and for discharge planning, specifically when you're implementing bundle payments? How does that look differently from what hospitals are typically doing today? And what are some of the best practices there that hospitals should be thinking about, specifically around your care coordination and case management strategy? So, we have a couple of guest speakers this afternoon who are experts in both of those topics. So, really excited to dive in there. We'll do a couple of introductions. We have a lot of new folks that have joined us since we have kicked off the collaborative in May. So again, my name is Ann, Director of Sales here at Avant-garde Health. Almost my entire career has been focused on value-based care and supporting organizations to transition to a more value model of care and certainly reimbursement model. I have a ton of experience in doing bundle payments, specifically in BPCI with orthopedic and cardiac bundles. So I'm really excited for team and supporting folks and being successful there. Derek, I'll toss to you.
Great. Thanks, Ann. Pleasure to be talking to everybody today. Very excited for the conversation around the outcome side of the team program. I'm the CEO and founder of Avant-garde Health and started the business in 2014. It grew out of work I was doing with two of the faculty members at Harvard Business School, Michael Porter, Bob Kaplan, co-leading their value-based healthcare research, and saw there's a ton of interest and excitement for people in the concepts. But it's clear people need software to help them take these ideas to be successful, implement in practice or institution. It's been, very exciting working with organizations in both the mandatory CGR knee and hip bundle payment program since 2016, and also more recently the BPCI Advanced Voluntary Bundle Payment Program since 2018 as well. And pass it to Porter.
Thanks, Derek. Good afternoon, and great to meet everyone that are joining for the first time. Welcome to the collaborative. Excited to have you. My name's Porter Jones. I'm the Chief Medical Officer. Prior to Avant-garde, spent about 7 years in hospital administration, which also included bundled payments. So really excited to work and learn from all of you. Welcome again, and Ann, I'll throw it back to you.
Awesome. Thanks, Porter. So a couple updates just to share with collaborative participants. We certainly want to extend a welcome for new health systems that are joining us. If this is your first webinar that you've been able to attend, we're glad you're here. Bundle payments is just a real passion project of ours. And we know that it's really great outcomes for patients. And then another thing I wanted to share is that with the baseline data that has been shared with participants, because you are a collaborative member, we're able to support the analysis of that baseline data along with the preliminary target prices that y'all have been given. So we can ingest that data into our bundled payment analytic platform so that you can see your data right within the platform and seeing how that looks and feels within the analytics. So all that's required there, we just need an SFTP to set that up to securely transport the data. So I know I've been talking with a lot of folks in setting that up already, but just wanted to make an announcement here that we would love to do that for you. And just another set of eyes and looking at your data and seeing what the opportunity is, and then specifically the financial implications of the data that you have so far. We are sharing all of our resources within the collaborative on a Google Drive. I know for Advocate Health, I've been sending it to you manually since their organization doesn't allow access to Google Drive, which is fine. So we have a lot of workarounds. But that's where all of our assets are housed. We do have a new one in there that I specifically wanted to call out since we last spoke. I know that there's been a lot of interest around the HCCs and how to capture those. What are the HCC codes that are important in team? So we have our data scientists created an HCC ICD-10 crosswalk. So a lot of really great information there. We have also been able to articulate and identified the diagnosis code. So it's not just a number, it's the actual name of what that diagnosis code is, again, to support providers in being able to focus on which ones are important when you're doing that pre-op risk assessment, when you're doing that pre-surgical visit. And then you can also filter it by bundle type. Our next webinar is going to be on Thursday, August 28th. So that will be an invite coming from me. We will have folks register for that. So that'll be a link that I'll put in my follow-up email to all the participants here. So just wanted to make that announcement as well. Okay, yeah. So just making sure, I know there's a comment about the resources. So we can do a workaround to make sure that you get all the resources. Awesome. So we're going to go into the next section of our meeting this afternoon, talking about the quality measures. So I'm super excited that Kat Vasilakos is here from Force Therapeutics. She's the Senior Clinical Operations Advisor at Force. So we've had a lot of really great conversations with Force. They're also in the value-based care space, specifically supporting patients post-operatively for surgical care, and helping to communicate and educate patients and facilitate communication between patients and providers. So Kat's going to take us through a couple of important metrics about the quality measures specifically. So I will toss it over to Kat.
Beautiful. Thank you so much, Anne. I'm just going to hop on the screen share here. And hopefully this works. Great. Everyone, let me know if you're having any trouble viewing my screen. But yes, Anne, thank you so much for that intro, and thank you to Avant-garde for inviting us to speak today on today's webinar. It's great to see everyone. Yes, my name is Kat Vasilakos. I'm a Senior Clinical Advisor at Force Therapeutics. Since joining Force in 2021, I've worked really closely with the quality folks and healthcare leaders at our clients to help them streamline their work, connect them with their patients, and really enable them to use data to help improve patient care. Just by way of background, before joining Force, I spent about 8 years working as an occupational therapist in and around the New York City area. So for today's discussion, we'll be reviewing the quality requirements, as Anne mentioned, that are included in this mandate. We're going to offer some example scenario calculations, diving into some of the common challenges and solutions that we see across the hospitals we work with. And then there will be time for a brief Q&A at the end as well. So while we are, I think at this point, all very familiar with the TEAM mandate and what it is, just as a very brief overview, TEAM is a 5-year episode-based payment model that's going to be running from January 2026 to December 2030. It is mandatory for a number of hospitals based in about a quarter of all core-based statistical areas. And these are the 5 procedure types that are included. So those are your lower extremity joint replacements, knees, hips, and ankles, surgical hip or femur fracture repairs, spinal fusions, CABG, and major bowel procedures. And so hospitals' performance within this model is ultimately based on 2 factors. So that's comparing the spending of a participating hospital's actual per episode spend versus the target price that Medicare sets for them. And then also performance on a number of quality measures, including things like readmissions, patient safety, and patient-reported outcomes. And that, the quality piece is what we're really going to focus on today. So when it comes to collecting and submitting quality data under TEAM, there are a few different elements that are required depending on performance year and procedure. So in performance year 1, all procedures are going to need to collect data on their hospital-wide readmissions and the PSI 90. So the hospital-wide readmissions is a hybrid measure because it combines your Medicare claims data with reported data from a hospital's EHR, including things like vitals, lab results, demographics, and comorbidities. And then the PSI 90 is a patient safety index, which is automatically calculated based on your claims data. And, within it, the existence of certain hospital-related indicators. So things like pressure ulcers, pneumothorax, sepsis, and a number of other in-hospital complications. And so in addition to these elements, hospitals are also going to be required to submit pro-PM data on their total hip and knee replacements, which, I'm sure mostly everyone on this call is aware of, if your hospital performs those procedures, but that piece involves submitting a matched set of pre-op and one-year patient-reported outcome forms, along with some pre-op quality proms and additional data elements as well. So that's for performance year 1. For performance years 2 through 5, the PSI 90 gets replaced by 3 other patient safety measures, and those are the hospital harm falls with injury, hospital harm post-op respiratory failure, and failure to rescue, which is also known as the 30-day risk. And that one refers to the death rate within 30 days of procedure among patients who've undergone a TEAM procedure. And these 3 patient safety measures that replace the PSI 90 are also claims-based. So for those, there's no manual submission process required. And so we've just put all of these quality requirements together in sort of a nice visual to kind of display what hospitals need to start with, and then what gets added or replaced as performance years progress. And now the one quality measure that I didn't mention is, you'll see in the rightmost column, and that's an additional information transfer aspect that has been proposed to be included for performance years 3 through 5. So this was just proposed a few months ago, in April of 2025, I believe, and it's not yet final, but what this would be is a one-time 9-question survey that's to be administered between 2 to 7 days after surgery. And the goal of that short survey is to collect patient feedback around the clarity of recovery information that they receive after discharge for TEAM procedures. So this would be another patient-reported outcome measure that would, I'd imagine, require some form of submission to CMS, being as it is patient-reported, and wouldn't be included in any claims data. And so we also just want to review, a few key terms related to this model, because there are a lot of them, and what they mean. So the reconciliation amount, that's the total dollar difference between the target price that CMS sets for a hospital compared to what that hospital actually spent to deliver that care for each qualifying episode. Positive amount here means that the hospital saved money, and the negative amount means that it overspent. The composite quality score, or CQS, this is the score that a hospital gets based on its overall performance across multiple quality measures. So the measures are scaled based on national percentiles, and then also gets weighted by the volume of episodes for each procedure at that hospital. So the final CQS is used to determine how much a hospital's quality performance influences payment. CQS adjustment percentage is the percentage used to modify a hospital's reconciliation amount based on their CQS. So higher quality scores, of course, lead to better adjustment percentages, so smaller reductions or larger gains, and then lower quality scores result in more of a negative financial impact. The CQS adjustment amount refers to the actual dollar amount that gets added to or subtracted from the reconciliation amount, based on that CQS percentage. So it essentially quantifies how much a hospital's quality performance affects its final payment. And then last one here, the quality adjusted reconciliation amount. This is really like your final number. So the QARA is that final amount that CMS either pays or recovers from a hospital after these quality adjustments are applied. And so the CQS is quite important. It's what CMS uses to adjust the reconciliation amounts that link quality performance to payment. The score is constructed by converting quality measures to scaled scores and then applying a weight to that score, as I mentioned, based on volume or the proportion of attributed episodes for each TEAM participant. So CMS doesn't just look at how well a hospital performs across different procedures, they also look at how often each procedure is done. So what that means is the more cases you perform in one episode category, the more that score counts towards your final quality score. So let's say your hospital performs 100 qualifying procedures under TEAM. 60 are hip replacements, 30 are spinal fusions, and 10 are bowel surgeries. Even though all 3 get quality scores, CMS doesn't really treat them all equally. So your hip replacements that make up 60% of your volume are going to have the score that carries the most weight. This approach kind of encourages hospitals to focus their quality improvement efforts where it matters most and on the procedures that they perform most often. So if 60% of your TEAM episodes are hip replacements, improving outcomes there can really have a significant impact on your final score and then ultimately your reimbursement. And this table here kind of just lays out the risk types and percentage caps by track. So track 1 offers only upside risk. Hospitals can earn a positive reconciliation amount based on performance with a CQS adjustment cap of up to 10%. There's also a stop gain limit of 10%, meaning that's the maximum amount that a hospital can earn above target. And in track 1, there is no downside risk. Track 2 introduces two-sided risk. So hospitals can either earn or owe money depending on their performance. The upside is capped at 10%, and the downside is capped at 15%. And there's a 5% stop loss limit that is meant to protect hospitals from excessive losses. And then we have track 3, which is really the most advanced risk sharing option. So it allows for both positive and negative reconciliation amounts. And in this track, both upside and downside risk are capped at 10%, but the stop loss limit here is higher at 20%. So a little bit riskier, a little bit more financial exposure on track 3. So we're going to go through a few examples of, how this might look. So this first example is of a hospital in track 1. So their reconciliation amount ends up being $250,000, meaning they were under that target price set by CMS. They end up with a composite quality score of about 66 and a CQS adjustment percentage of 3.39%. And just a reminder here that percentage would not be able to be above 10% in track 1. That percentage is then multiplied by the reconciliation amount to get the quality adjustment amount of $8,475. That amount is then subtracted from the original reconciliation amount to get the QARA, that final number, which then gets multiplied by the stop gain percentage on track 1 to get the hospital the final figure of $241,000 around that will be repaid to them. And that last row there, so, just a note that because that, final QARA is under the gain loss cap, that cap doesn't apply and the hospital obviously gets to recoup that amount. Oh, let's just back up there. So this example is quite similar, but what we wanted to highlight here was the impact that a higher quality score gets you when it comes to, that final figure. So, higher quality score results in actually what ends up looking like a lower CQS adjustment percentage, but that's actually what you want because that's what's going to result in less being subtracted from your reconciliation amount. And so you can see in this example, higher quality score of 80 compared to the last examples, around 66, is ending up resulting in a slightly higher final amount than in that previous example with the lower quality score. Now, on the flip side of this, this is an example of a hospital on track 3, so that slightly riskier track. And this hospital ends up losing money. And so you can see they've had to start a negative reconciliation amount, and even with a decent quality score, they end up owing back money. And so I just want to point out that $900,000 figure at the bottom there, that's what, a hospital in this situation could stand to lose on this track. It's what they could stand to gain, but also, riskier track, it's what they could stand to lose. So you can see how these formulas can be used to plug in a particular hospital's numbers and see, depending on the track, depending on their, quality results, what an organization might stand to lose or gain within this model. Great. So based on what we've seen with things like ProPM and our clients that have experience with quality and other bundled payment programs like CJR, and also what some of our clients that are included in this mandate and are thinking about it have expressed to us, we've identified what we anticipate being 4 top challenges for team hospitals, and then also ways to approach them. So the first challenge that we see relating to team down the line, and that honestly we already see in a bunch of different contexts with our clients, is care plan variation. So, the lack of standardization in patient care plans, as many of us probably on this call know, can already cause a whole list of problems, but through the lens of team, are very likely to cause overinflation of cost. So, of course, implementing digital solutions can be really valuable here. But one thing that we like to highlight is that it's especially important to introduce a solution that's able to support global standardization with certain levels of personalization where it's needed. Because, while maintaining standardization where possible is key for cost containment, we also, of course, know that not every patient is the same, and we do need to make sure that we account for that. And then the ability to have access to and leverage clinical insights and data to be able to make refinements and changes to care pathways with as quick a turnaround time as possible is super important. So, for this challenge, really what you want is the ability to have access to patient outcomes in order to be able to really drive care redesign and, view what's happening and ensure that your program for, whatever team procedure is continuing to evolve where it matters most. The second challenge, that we identified is missing that 1-year matched PROMs requirement. Now, this is a challenge that will really only apply to the lower extremity joint replacement cases, and even within that, just the hips and the knees. But a few things there. So, A, those cases are not unlikely to be some of the highest volume cases for a lot of hospitals. And B, this is something that really can be seen as, I think, sort of low-hanging fruit or an easier win for a lot of hospitals because it's patient-reported data. It's PROMs collection. It doesn't have to do with hospital complications or readmissions. And so what we hear around this is, we have a lot of experience with this. Typically, getting the pre-op PROMs is not so much of a challenge. But when it comes to those 1-year matched PROMs, a year is a long time for patients, and it's really hard to get those collected. But the problem is if you're not collecting at least 50% of those for the eligible patients, you're out of compliance. So luckily, we've been able to kind of gather the most effective ways to capture those 1-year collection rates, and I'll just run through them quick, but the first is really to just keep patients engaged during that time for as long as possible during their recovery, educating them well in advance about why PROMs are so important to fill out, getting visibility into the patients that either have not or are at risk to not fill out and complete their PROMs. That's huge because the earlier you can intervene, the better. And then finally, to review reporting regularly. And so whether that's through your EHR, if it has that capability, or through a digital solution to support PROMs collection, staying on top of where you stand regularly so that you can ensure you're on track is really important when it comes to all this. And then another challenge that we've identified will just be the lack of patient compliance to their recovery plans. So this is not an uncommon thing that I'm sure, a lot of us here can relate to. And obviously, again, this also poses kind of a whole list of problems, but within the context of team, patient noncompliance is a really big driver of higher costs. So it's really important to ensure that the care plans patients are expected to follow are clear and accessible. Because, as patients, when we understand what we're supposed to be doing, we're much more likely to actually do it. And digitizing the recovery process can really help here. The vast majority of patients are used to some form of technology and really even come to expect it now when it comes to their health, whether that's in the form of an EHR or maybe an app-based health portal. And then of course establishing that effective communication between your teams and your patients really can help immensely when it comes to patient compliance that we found. When patients feel like they can get answers to their questions, doesn't even really matter so much how they're getting those answers, just that they feel connected to their care team in some way, that really helps bolster compliance. And then the last challenge that we've identified is the data collection, extraction, and submission piece. And it is time consuming, time that staff members often simply don't have, which is why, it's so important to streamline that process where possible. We work with clients from all different types of hospitals, some with large quality teams that can support this, to some who really don't have anyone, dedicated specifically to these types of quality initiatives. But the things that we've seen work really well for even the smallest teams are to leverage technology that can extract the data and format it for you. Doing this manually is extremely time consuming, and especially if it's a larger volume of patients, trying to stay on top of everything manually, it just really isn't realistic or scalable. And so then also utilizing some form of digital submission so that when it comes to the patient-reported aspects of this model, as many patients as possible can submit directly and minimize the amount of manual submission that has to occur. And then finally, establishing and fine-tuning standardized data collection and storage workflows to hopefully reduce variability and ensure consistency where possible. The vast majority of our clients say that with these types of quality initiatives, it's really all about the process and, identifying the right people to be involved. And so most of the time, step one really just needs to be setting that up, finding the right stakeholders internally that need to be aware, and then making sure that everyone involved is, following the agreed upon process. Great. So kind of ran through that quickly, but wanted to definitely make sure that there was time for some questions if anyone had, or thoughts or insights.
There's one question in the chat, Kat, that he asked, does the PROMS post-op collection begin at day 300 similar to the current CMS mandate, or is it a full year post-op?
That's exactly right. Yep, that's day 300 to 425 for that aspect. If what you're referencing is the Pro PM, then yeah, no problem. Great, and I think I stayed on time there.
Indeed. Any other questions for Kat?
All right. Well, if any questions come up, after the fact, or if there's anything we didn't get to cover, if you can connect with Anne, I'm sure that she can provide them to us, and we can definitely compile some responses for everyone.
Awesome. Thanks so much, Kat.
Thanks, Anne. Thanks, everyone.
Thank you.
Cool. Well, we will move on to our next presenter. So really, yeah, I'm really excited about this, about the discharge planning, just kind of getting into more of the clinical case management aspects of doing bundled payments and what we know has been successful. So I'm really pleased to introduce Sherry Eisenstein. She currently works with Spectrum Medical Partners in Florida, where she focuses on improving outcomes for patients in the ACO population. But Sherry's been doing bundled payments since 2015, specifically working with a large orthopedic practice in Florida and then consulting nationally with other case managers, with other clinical leaders and surgeons who are doing bundled payments. So really excited to turn the floor to Sherry to share a bit about discharge planning and what hospitals and health systems should be thinking about as they build out their programs. So Sherry, I'll toss to you.
Thanks, Anne. All right. Hi, everybody. Kat, you made a very dry subject very good to follow. So thank you. All right. Can you all see the slide deck?
You can.
Great. All right. All righty. So I've been in bundle payments for 10 years, like Anne said, and I'm quite passionate about it. I'm a registered nurse. I'm a certified case manager. And I feel like TEAM and BPCI, the program it replaces, provides great service to Medicare beneficiaries. It's like a concierge level type service, and who doesn't want someone to help hold their hand, whether it be in person or telephonically through a stressful event such as a surgery, no matter what type of surgery it is. So my passion will show during the presentation. So if you think about what's always been in terms of medical care and what Medicare is trying to improve on, you go from the status quo to value-based care, and TEAM being the newest value-based care program. In status quo, you have poorly managed transitions. Medicare reports about $26 billion a year is lost due to poor transition of care. And that could include going to the wrong post-acute facility, readmissions, medication errors, anything that can happen during that post-acute time. Whereas TEAM is going to minimize as much as possible by doing standardized care, like Kat was referencing, based upon evidence-based medicine, and having consistent messaging from the surgeon, from the hospital staff, from any navigators, care managers, that the patient and the family are hearing the same thing over and over again. And then the patient says, oh, everybody's telling me this. I can do that. Status quo, there's delays in discharges. How many times do I read records and the patient's ready to go to a SNF, but hasn't been accepted yet? The family wants inpatient rehab, but the facility is saying subacute rehab. So you have to evaluate those different levels of care. But now the case manager is going to be more of an integral role in deciding what level of care this patient needs, along with the medical attending and the surgeon. Discharging from a hospital too soon. Hospitals want their patients out. They're getting their DRG payment. And when I look at data, when a patient's transferred to a SNF, and I see a lot of transfers back to a hospital within 1 to 3 days, I'm looking at, was that patient transferred too soon? Perhaps this patient still needed some acute level care. And I've seen that quite a bit, but the hospital's like, get him out, get him out, get him out. Whereas in BPCI and L TEAM, sometimes we say, whoa, let's keep this patient another day, make sure they are stable, and avoid that readmission. So as you know, the old verbiage is, it takes money to make money. This is one of those cases. Discharging to the wrong location for the patient. Patient's daughter says, I want my patient going to the inpatient rehab down the street. It's gorgeous. I've seen it. I've had friends' parents who've gone there. They've done really well. But this daughter's mom is 93 years old, just had a hip fracture, has some dementia, and perhaps inpatient rehab is not the appropriate level of care for her. And therefore, that patient needs subacute rehab, which is your SNF level of care. So we need to be more forceful, more direct in getting patients to go to the right place. And when we learn utilization review as nurses, and I do have a UR background as well as part of my case management background, we look at, it's the right patient, the right amount of time at the right place. So is inpatient rehab the appropriate level of care? In my 3.5 years of doing a BPCI program for a large ortho practice, doing knee replacements, hip replacements, and hip fractures, only 3 patients I felt needed inpatient rehab. And I'll go into that in a couple minutes too. You'll see increased rate of readmissions, whereas when you have standardization, patient optimization, you're going to have less readmissions. Again, patients and families know what to do. And for the procedures that you can improve outcomes on based upon improved optimization, patients are going to do better, less problems. And then monitoring your post-acute providers as well as constant contact with that patient. The preferred call cadence would be 1 business day after discharge, 1 week, 2 weeks, 3 weeks, 4 weeks during the 30-day episode, and then PRN is needed. So you're going to develop your discharge plan, and we learn in nursing, discharge plan always starts upon admission. But in a program like this, your discharge planning starts the day that that surgeon says, Mrs. Smith, you need surgery. You need a CABG, you need a knee replacement, you need a hip replacement, you need spinal fusion. And that messaging starts then. Mrs. Smith, I know you can go home after this procedure. All of my patients go home and you're going to do great. Medication reconciliation needs to happen at every touch point. Every time a coordinator, case manager reaches out to that patient, making sure that patient can afford their medications. How many times I've seen post-op ortho patients go home on a blood thinner like Eliquis or Xarelto, and that patient cannot afford it. Whereas other orthopods throughout the country use aspirin unless the patient's allergic or has GI issues. So making sure that patient can afford it, because again, as Kat was saying, patient compliance is a very important part of this program. Coordinating follow-up appointments. A lot of orthos don't see their patients, and I'm not sure specifically about heart surgeons, but have traditionally seen patients at that 6-week post-op. But when they're in a value-based care program, we want them seen at 2 weeks, because at 2 weeks you're going to find what problems the patient's having with their recovery, whether it's the incisions not looking good, or the patient has questions, patient's not being compliant with whatever therapy precautions they have, or has a lot of questions at that point, or if the patient did go to a SNF, because SNFs are so used to keeping Medicare patients for so long, that's a time for the surgeon to intervene and say, Mrs. Smith, I think you're doing great. I know the rehab's telling you need to stay for another 2 to 3 weeks, but I think it's time to go home. Patients who go home do better. And again, that consistent messaging makes a difference. The other one is having that call with the visit with the primary care provider within 1 week, because they're managing those medical comorbidities, which often get stressed by surgery, especially diabetes, congestive heart failure, anything else that can have problems to have post-op complications on. It also helps notifying that primary care provider before surgery, dear doctor, your patient is having surgery. Here's the goals of the value-based care program we're participating in. Part of that is we don't like to send patients to rehab, because a lot of primary care providers will tell their patients, oh, I go to that rehab on Elm Street. I can get you in no problem, and you can stay for a few weeks. So the goal of this is to avoid this as much as possible. Preoperatively, arranging as many resources as you can, whether it be post-op transportation to and from physician appointments, physical therapy, telling that patient it's okay to ask your friends and family for help. You'll make it up to them after you recover. Because everybody in this age group tends to have some type of medical encounter where they need help, or there's always Uber to arrange for transportation as well. Making sure they have enough healthy meals for recovery. They all need protein for healthy recovery. Start cooking for the freezer. Arrange for people to bring you healthy meals. This is not your time to start eating at McDonald's, because you want healthy food with lots of nutrients for recovery. Do you need a ramp? Because you have too many steps. Maybe this is the time you've been thinking about it, and this is the time to reach out to your church and say, you know what, is there anybody around who can help us build a ramp to our home? Arrange for medication delivery if needed. A lot of hospitals have a delivery service that medications from the local pharmacy can be delivered to the bedside before the patient's discharged so that they don't have to stop there on the way home. Someone to stay with the patient. How many times do I see, especially for hips and knees, because of all the surgeries that team, is using, that's more of a healthy type surgery. I've had both. And yeah, we don't want you going to rehab because you don't have somebody. Private insurances most often don't pay for a SNF stay for a social reason like that. It's okay to ask your friends and family to come stay with you 3 days, 4 days, a week. They'd love to help you in most cases. And think about what remote patient monitoring systems you have access to. I've never used one personally, but I think it could be a big asset to the program to send a text reminder out to a patient. Don't think that your 80-year-old does not have a smartphone, because majority of them do. I've seen 85-year-olds just whip out their phones when I've rounded on patients and say, oh, let me look up that medication now, or let me look up that place. They do have access. And this could be a quick, easy text. Have you had a fever in the last 24 hours? How many times are you getting out of bed to walk? How far are you walking? And there could be flags sent to the navigator team that if the patient's not meeting metrics on any given day, that's going to trigger an additional call. So you want to think about, in terms of deciding on that discharge plan for a patient, the different levels of care. As I said before, for any nurses who do this, we learn when we give medication, the right place patient, the right dose. And so you think about the same things. It's the right patient, right treatment, right place for the right amount of time. And the reason I include the cost here is because you have your bucket that you're allowed, you have your target price, and all of this is going to take away from that target price that Medicare is giving you. So if a patient goes to an LTAC for some reason, that's going to average $30,000 against your target price, and that's a big loss. Some of the reasons you'll see LTAC would be patients who can't be placed in a SNF. They're an event, they have trachs, or patients who have overused their SNF stays based upon what's allowed with Medicare, and therefore they don't have any skilled days left, so therefore they have to go to LTAC. Or patients who are on high cost medications and therefore the SNF can't take them, because SNFs are reimbursed about $650 a day right now. Might be a little bit lower depending where you are geographically, but it's about averaging $650 a day now, with an average length of stay of 31.4 days. Home health care is an episodic payment, just like hospitals are paid via DRGs. The average patient's going to be about $2,500 to $3,500 a case. So back to that status quo slide, but just because you've always sent patients through home health care doesn't mean we need to do that now. One of the things a lot of groups implemented in BPCI is getting rid of home health care altogether, and introducing more outpatient therapy right away. When I had my hip replacement, based upon my best surgeon who did at my ortho practice that I was running their bundle, he was our first provider to use outpatient therapy. I started my outpatient therapy on day 4 post-op, and I had great outcomes. And when we implemented this across the board in our group, our physical therapy staff, because we had physical therapy offices at all our ortho offices, told me that they were seeing patients with much better outcomes this way. Patients reached improved flexion for the knees, extension with the knees, balance, strength. overall for hips and knees, fractures, sooner by coming straight to outpatient therapy versus home health care. The only time that I would recommend home health care for my ortho patients was when I needed nursing eyes and ears in the home, because that patient had a lot of medical comorbidities that I thought were going to be a problem. I needed a nurse out there to listen to lung sounds, for example, to make sure that patient wasn't retaining fluid with congestive heart failure. Always think about prior level of function when you're deciding on that post-op level of care. And what I'm doing now, I coordinate care for a lot of our Spectrum's ACO partners, as well as our MSO partners. And I just recently saw a request for a patient who's 93 years old with some dementia. She's currently inpatient with a medical diagnosis, and they're requesting inpatient rehab. So I already reached out to my attending, saying, hey, this patient's not appropriate for inpatient rehab. Let's try to work on subacute rehab for this patient. That's definitely within the scope of what she needs. Always remember, as Dorothy in the Wizard of Oz said, as she clicked those beautiful red slippers, there's no place like home. And just because patients say their best friend went to the sniff down the road and did great, they had lobster every Friday night, not really lobster, but because the food usually stinks, it sniffs. But, they think it's great because they're going to get PT twice a day, but the patients are going to do better going home because they get to move around more often. Think about the differences between the facilities when you are deciding on your level of care. Both facilities can offer a lot of rehab, especially as you develop your post-acute network, which is really important in this program, to identify 5 to 7 SNFs in your area that you want to fill their beds versus 20 SNFs that you routinely send patients to. Yes, their lengths of stay will be shorter, but by having a post-acute provider network, you're going to fill those beds more often and keep them filled. That's what the SNF cares about, is having their beds filled. So one of the big differences of when I decide where a patient needs to go is physician involvement. Inpatient rehab is going to have 7-day coverage of a physician or physiatrist who is going to evaluate that changes, especially in their comorbidities. That's going to impact their recovery and decrease readmissions. And at skilled facilities, there's SNFists. One of the things that a lot of hospitals do that improve outcomes is either partner with a SNFist group, like the one I'm employed at in different areas in Florida. And therefore, as a SNFist group, we know what the intended outcomes are of these patients who are identified in these programs. We know you want lengths of stay that are shorter. We know we want to prevent ER visits as well as readmissions. Or if there's not a group, develop your own. Get your own SNFists on board at some of these post-acute providers. Difference in nursing. In inpatient rehab, you're going to have more RNs, whereas in a SNF, you're going to have more LPNs. And think about the acuity of patients. In the dinosaur days when I became a nurse, cabbages went in 2 days pre-op and stayed 10 days post-op. Now, no pre-op, and they go home 4 days later. So patients are, granted, the surgery's improved a lot, but patients are overall sicker when they go to a SNF now. So think about that level of care that needs to be provided. Inpatient rehab is covered as a hospital stay would be. It's episodic. It's covered under Medicare A. SNF is covered at 100%, again, under Medicare A. And both are multidisciplinary. So if an inpatient rehab tells you, oh, we're multidisciplinary and a SNF is not, that's not true, because all SNFs have multidisciplinary meetings 5 days a week. Think about, does your hospital have a TCU, a transitional care unit? They bill the same as a SNF, that average of $650 a day. And it becomes a win-win because you're capturing your own patients that are in the program and everybody is on board with what the goals are. So here's a case study of a patient of when I was responsible for hip fracture patients. 96-year-old with a hip fracture. Patient has congestive heart failure, diabetes, and chronic kidney failure. I don't know what level, but not end stage. And this patient, because the case manager had not been informed of this patient, 96-year-old, went to inpatient rehab for a cost of $26,000, then was discharged from inpatient rehab to the SNF, which cost $7,000. This is based upon true Medicare claims. Had this patient been followed by a case manager, gone to the appropriate level of care, which would have been a SNF off the board, the cost difference would have been $14,000, which could make or break your bundle. So discharge planning for home health, the patient needs to be homebound, which means unable to leave due to an injury or illness that restricts ability to leave. I've had home health care say just because a patient uses a walker means they're homebound, and that is not useful. Because how many times do you go out to the mall, to your favorite restaurant, and you see, a patient out there getting their own walker out of the car because they drove? And so a walker does not make this. This means a patient really can't get out. They can't go out to lunch with their friends. They can't just go out, to the movies. Yes, they can get out to doctors' visits. They can, they can do the basics, but that's allowed. They need to have at least one skilled service, RN, PTOT, speech. Care is intermittent. It's about 1 hour visits, but a lot of that visit is doing Medicare paperwork. So it's about 30 minutes for nursing. Think of if you need skilled services such as wound care or professional eyes, ears due to comorbidities. Routine wound care does not count as nursing care, in my opinion, to look at a dressing that is dry and intact. Physical therapists are quite capable on doing that. You do not need nursing unless there's like a wound vac or some wet to dry dressing changes or something like that. Think about optimizing the use of outpatient PT, or for your spine cases, even not doing physical therapy in the beginning, because those patients cannot, basically cannot bend, lift, or twist, BLTs, and therefore save that outpatient physical therapy benefit for when they can use physical therapy and need to increase their strength, balance, and endurance. And a lot of surgeons don't use physical therapy right off the bat. And again, back to the status quo, just because we've always done that, save that for later. The other thing a lot of groups throughout the country have started using is not using their traditional home care companies, which bill under Medicare A, but using companies out there that bill under Medicare B, which is a per visit physical therapy versus episodic. And we've had really good outcomes doing this with tremendous cost savings of about $2,000 per patient for those patients who do need to have therapy at home but can't go out as easily. Your consultant in the TEAM program is going to be providing you with a lot of data. And this is based upon data for the company that was my consultant when I ran my program. And this is why you want to have preferred and non-preferred providers as you develop your post-acute network. You can see that I was really using my preferred network, which is in the green. And you can see the difference in average length of stay of preferred versus non-preferred, and in readmissions when I use preferred over non-preferred. Dramatic difference. And this is going to make a huge impact in generating your revenue off the program and really proving that the TEAM program is beneficial to Medicare, to your facility, to earn, as a revenue source, and most importantly to your patients, because I don't know of anybody who says, oh, I want to go back to the hospital in 4 days. So this is really important to constantly be monitoring your post-acute data, and then always realigning your post-acute network. I used to have post-acute facilities that were favorites, and they came off my list in 6 months based upon data. I'm like, yeah, the data is showing me, patient satisfaction is showing me that even though you're a 4 or 5 star facility, according to Medicare Compare, you're not meeting our metrics right now. So some of your common barriers would be if your patients want to go to a swing bed at a critical access hospital. These are your rural hospitals that are identified as a critical access hospital. That means there's no SNF that is near that patient most likely. And the critical access hospital can basically bill what they want. It's a way to help them have filled beds. And right now, with all the changes that are going on with Medicaid and everything, what's going to happen to these rural hospitals? And, are they going to stay in business? So it's important to keep your patients out of these swing beds. I've seen them cost as much as $4,000 to $6,000 a day. And this is for subacute level of care, that if the patient needs a SNF, that is that $600, $650. So it's important to be monitoring your patients for where they want to go, and for them not to go home and call their primary care provider out in the community who says, oh, I'll just send you to that hospital that's, a mile down the road, and I can get you admitted there because that patient had a qualifying in 3-day stay. Again, consistent messaging is the most important thing. It starts with the physicians. If your physician says to all their patients, you can go home, you're going to do great. All my patients go home. They do so much better from when they went to rehab facilities. They're not having problems. Evidence shows there's a lot less falls. Data shows there's a lot less infections, a lot less readmissions, and we can get you home. And that consistent messaging is your key to success. And you have to include that family in the discharge planning. Family member or that significant other should be attending that pre-op visit with the patient, as well as any classes that the hospital offers. Whether you offer your knee camp, hip camp, spine camp, if you have a cabbage camp or cabbage teaching, whatever teaching you do preoperatively at the hospital level, everything needs to be consistent. I once a couple times I attended the knee class, hip class, joint class from a hospital, and their message was, we want you to go home. However, part of that class was a person from the local SNF doing a presentation. Well, that's very confusing. You're telling me don't go there, but now you're telling me they're here. The message has to be consistent. We don't want you going.
I know, Sherry, that we're right at time, and
Great.
we just had one. I know we have one of the questions that came in that I just want to make sure that we address before we wrapped.
Sure thing.
One of the question was, I know that a lot of organizations are thinking about caseload and resources to allocate for case management, since most hospitals do not have a role like this already in place, certainly not for their surgical cases. So in your opinion, what would you recommend would be, the question is, patients to case management ratio, like how many, for FTE, for a full-time FTE, how many patients can that person manage?
I think because the program being 30 days, I'm thinking about 450 to 550 cases per year, depending on their population. What's the acuity? Patients are more time intensive to get them ready for surgery, as well as that first week or so after. And then also if they go to a post-acute facility, it requires more coordination of care time, trying to get them out sooner. So depending what your baseline data shows you. And in the beginning, it's going to be more work than as you continue the program, and that consistent messaging gets on board with everybody.
Excellent, thank you. Any other last questions for Sherry? Okay, great. Well, Sherry, thank you
Thanks.
so much for sharing all of your expertise and knowledge. And Kat, thank you again for going through the quality metrics there and ways that folks can be successful. So thanks everybody so much for joining, and we'll send out a follow-up email with the recording and a couple of other additional resources and next steps for us together as a collaborative. So thanks everybody so much. Have a great rest of your day.
Thanks, Anne.